Hello, and welcome to Improving Migraine Management in Primary Care, the role of CGRP antagonism. I'm Dr. Linda Davis, and I'm a family medicine physician and the medical director of Colvita Family Medical Group in Mission Viejo, California. And thank you for joining us. This is to acknowledge the sponsorship and support. This presentation is sponsored by Primary Care Education Consortium, and it is supported by an educational grant from Pfizer Incorporated. CME and CE information for enduring education. The AFP has reviewed improving migraine management in primary care and deemed it acceptable for up to one enduring materials self-study AFP prescribed credit. And the term of approval is from September of this year, 2024, through August 31st of 2025. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Following this CME activity, participants will have the opportunity to earn an additional 2 prescribed credits for participation in each translation to practice exercise, which I will explain. So what is translation to practice? You may qualify for an additional 2 credits if you make a commitment to change your practice behaviors in your post-presentation survey. In that survey, you will be asked 3 things: to commit to changes in your practice behaviors, to specify what those changes are, and thirdly, to provide your name and email address. If you do not enter the required data mentioned above, you will not be eligible for those extra credits, so please include all that information. Approximately 6 weeks after you complete the course, we will contact you asking if those changes have been implemented in your practice and asking some additional questions. If you have completed those changes, you'll be eligible to complete the survey and generate a certificate for the additional credits. CME information for NPs and PAs are as follows. Faculty disclosure information. The Primary Care Education Consortium adheres to all the required prerequisites in order to make sure that this presentation has been mitigated for any conflicts of interest and it's unbiased. Here are our disclosures. So my disclosures are up top, and the medical writer and CME reviewer have no disclosures to report. So once again, all relevant financial relationships have been mitigated. What are our learning objectives for the next 45 minutes or so? Participants in this presentation should be able to, number 1, describe the role of CGRP in the pathophysiology of migraine headache. Number 2, describe the role of targeted CGRP therapy and approved CGRP antagonists in the acute and preventive treatment of migraine headache. And third, describe patient preferences and how they may impact drug compliance and treatment outcomes. Here's our outline for the different topics that we will be discussing. So the first section is definition and classification. So what is a migraine? First, it's important to recognize that migraine is the second most common cause of primary headache after tension headache. However, it is the most common type of primary headache seen in primary care. This is a table comparing tension headache and migraine. So age of onset for tension headache, between 20 and 50 years old. This is the kind of typical headache that most of us have experienced at some point in our life. Kind of some achiness, maybe a band-like sensation around our head. And typically it doesn't really interrupt our ability to function and do our daily activities. Maybe we take an over-the-counter analgesic, maybe we just power through it. They're usually not too impactful. A migraine, however, age of onset can be as early as 10 years up to 40 years old, and then can last, of course, later into life. It's usually unilateral, but not always. And the intensity is moderate to severe. So this is a big distinguishing point from tension headaches, where it's usually mild to moderate. Another key point is migraine headaches can last, a migraine attack can last for 4 to 72 hours. So up to 3 days of this headache. It's a throbbing sensation typically. And we also can see prodromal symptoms and aura with migraine, which we'll get into that shortly. So in summary, a migraine is a complex neurological disorder that is usually characterized by unilateral headache, often throbbing in nature, can last 4 to 72 hours. Sometimes you'll see sensitivity to light and sound. About 80% of patients will complain of nausea, and 50% of patients will actually vomit with their migraine headache. The ICHD-3 criteria, so the International Classification of Headache Disorders, version 3, third edition, diagnosis of migraine without aura is at least 5 attacks that lasts between that 4 and 72 hours. And during the headache, at least two of the following on the left column. So unilateral location, pulsatile inequality, moderate to severe pain, and aggravation or avoidance of physical activity may be seen. So you need two of those, along with one of them on the right-hand column. So either nausea and or vomiting, photophobia and photophobia, or it's not better accounted for by another ICHD3 diagnosis. Diagnosis of migraine with aura includes the original migraine diagnosis, and then you must have at least two attacks with one or more of the following fully reversible aura symptoms. So that's key, fully reversible. May be visual, sensory, speech and or language, motor, brainstem, or retinal. And you have to have at least three of the following. At least one aura symptoms spreads gradually over 5 or more minutes, two or more occur in succession. Each aura symptoms last between 5 and 60 minutes. At least one aura symptom is unilateral. At least one aura symptom is positive, and aura is accompanied or followed by headache within 60 minutes. I always like to point out patients can have an aura from a migraine, but not necessarily have a headache with it each time. I also like to point out that patients who have aura with their migraine, not every migraine has to have an aura. We're busy. Primary care, we are busy. We are tasked with a lot of disease states to go over, a lot of preventative maintenance. So I'd love to have this little quick diagnosis for the busy PCP. This is a validated screener called ID Migraine. And what I tell my staff to do is if a patient comes in complaining of a headache, give them this screener before I even go in there. The screener basically says is during the last 3 months, when you've had a headache, are you yes or no for the three following questions? First, have you ever felt nauseated or sick to your stomach? Yes or no? Has light bothered you a lot more than when you don't have a headache? Or are your headaches limiting your ability to work, study, or do what you need to do? If you have 2 out of 3 of these positive answers in the yes category, it's a high sensitivity and specificity that this is a migraine. So very quick, very easy way to identify and feel pretty confident that these patients are having a migraine. Migraines can also be classified based on frequency, and classification does affect our treatment choices. So, as we progress into different options for both acute and preventive treatment, the lines between episodic and chronic migraine are getting a little bit more blurred. This was very, very important originally when onabotulinum toxin A first came on the market, which we'll talk about a little bit later, but that was only FDA approved for chronic migraine. So it was very important at that point that a practitioner could identify whether or not this was an episodic migraine or chronic migraine. The other reason this is important to know is the level of disability, because we do see that as we progress from episodic into that chronic status, the level of disability does increase. So we define episodic migraine as less than 15 days, so 14 days or less per month of headache frequency. A chronic migraine, they complain of 15 or more headache days, of which 8 of them have to meet the criteria for a migraine in order to be a chronic migraine. Section 2, what are the phases of migraine? So we really are emphasizing in today's headache world that migraine is not just about the attack or the headache portion of it, which is usually the most severe portion, but there's actually prodrome, or what's also called the premonitory phase of migraine, as well as those patients who have aura. And this precedes the headache, and it can be hours or days leading up to this headache. And then following the headache, many patients will describe a postdrome, almost like it kind of reminds me of that postictal phase after somebody has a seizure. They're still left with some residual symptoms. And then there is something called an interictal phase, which is the phase between when a prodrome and that starts progressing into the migraine headache and then ending with the postdrome. And this is kind of a continuum. So we really are treating migraine now as a continuous disease state and not just focusing on that attack. The prodrome phase occurs in 60% of patients with migraine, can occur hours to days, as I mentioned before the headache. They might have heightened sensitivity to light and sound. They may feel more lethargic, uncontrollable yawning. They may experience some mood changes, changes in bowel movements, excessive thirst, and polyuria. About 20% of patients, the headache phase is also preceded by an aura. What is an aura? An aura is a set of complex neurological symptoms that precede or accompany migraines or occur in isolation. So once again, I said you can always have an aura and not necessarily get the migraine headache after. They're typically visual, sensory, motor, or a combination. Visual auras are the most common form of aura, and the aura phase or cortical phenomena is a result of cellular depolarization of neurons and glial cells in the cerebral cortex. So something a patient might describe to you is something called photopsia, which is almost like these little lightning episodes of bright lights that they might see in their vision. They might describe a fortification spectrum, which is also sort of a light visual experience where they have a almost geographic or geometric pattern. And it got its name because a lot of people described it almost as a medieval fort, looked like a fort to them. Scintillating scotoma. So scotoma is blind spot, and scintillating can mean a wavy or a variable blind spot. Sometimes it's by color, sometimes it's by shape. When we talk about the headache, once again, I'm going to emphasize this several times. The maximal pain occurs during that headache phase, and that can last between 4 and 72 hours. So one migraine attack can last up to 3 days. The post-Trump phase is the winding down phase with mild symptoms. So they might still feel some fatigue. They might even have some euphoria, myalgia, anorexia, or even some food cravings. That interictal phase that I mentioned is really the phase between that whole migraine attack. The mild symptoms may persist, though rarely, and usually patients experience some trepidation, especially for our patients with high frequency episodic migraine or chronic migraine. They might hesitate to make plans or go out and do things, even scheduling a vacation because they're not sure when their next attack is going to come. Epidemiology. So, why are we talking about this? How common is migraine? About 1 billion people worldwide suffer from migraine. And depending on which data and when you pull it from, it's anywhere between 12 and up to 14%. Here we're quoting 13% prevalence in the United States, which is approximately 39 million Americans. Other diseases with a similar prevalence can be type 2 diabetes as well as asthma. There is a female predominance, which with about 18% of women have migraine and 6 to 7% of men. It is once again the most common neurologic disease seen in primary care and the most common type of primary headache seen in primary care. The United States actually has the highest prevalence of migraines in the world. Here, with this data, was more than 30 million Americans. My previous slide mentioned up to 39 million experience one or more migraines per year. And according to the WHO, the worldwide lifetime prevalence of migraines is about 14%. Once again, women are more likely to experience migraines than men, and 75% of all persons who experience migraine are women. 1 in 6 American women experience migraines. It is important to note that prevalence of the U.S. of migraine in the U.S. of the underrepresented groups. You'll see here actually Native Americans have a higher prevalence even than Caucasians, although we frequently attribute the typical white woman as having migraine attacks, but actually Native Americans have a higher prevalence. And then Hispanics and Blacks are fairly close with Caucasians, with Asians representing the lowest prevalence in the United States for migraine. Migraine carries a very high disability, which is why this is also extremely important that we're having this conversation. One of the leading causes of disability worldwide, it's the second cause of years lived with disability, follows just shortly after low back pain, but it's the number one in women under 50. And I think that's very important to take home because if we think of our female patients under the age of 50, this is their most productive time. This is often when they're going to college or graduating from college, maybe starting their careers, maybe starting a family. So to have a high disabling disease during this time period is very impactful for them. The peak in ages for both men and women is between the ages of 22 and 55, affects 1 in every 4 households in the US, and it has a high socioeconomic burden. The annual total cost in the US is estimated around 36 billion. There's both direct and indirect costs, and for patients who have a diagnosis of migraine, these combination of costs is $9,000 more per year than patients with overall similarities, but not a diagnosis of migraine. They also have a negative impact on the overall economy. 40% of adults with chronic migraines are unemployed. I don't know about you, but for me, one of the most common reasons I fill out those FMLA forms is for my patients with migraines. They have unpredictable attacks with severe levels of disability, and they can't function, they can't work during those times. Migraines are responsible for 4 million ER visits annually, and they're responsible for approximately $13 billion lost of productive time in the workforce every year. We talk about absenteeism, which is being missing from work, but there's also an expression called presenteeism. So we might be at work, but how functionable are we if we're suffering from a migraine attack? How present are we in our job? This is a very important slide, and I feel like this diagram gives us a real insight into what we mean by disability. And I like to call out the fact that when a patient has 4 or more headache days per month, they get this jump in disability. And I want to once again specify I'm talking about headache days, not migraine attacks, because we said that the headache of a migraine attack may last for up to 72 hours. So you might only have 2 migraine attacks a month. But if each one of them is lasting 48 to 72 hours, you are already exceeding that 4-day threshold of headache, and your disability goes up. Once again, talking about high frequency episodic and moving into chronic migraine, you can see where their disability ratings go as well. Migraines in primary care. So, why are we having this conversation? Is it this mostly in the neurologist's office or a headache specialist? No. So, greater than 37% of women of reproductive age in a primary care provider's waiting room meets the criteria for migraine, whether they're there for their annual pap smear or whether they're there because they have a cold. If you go into your waiting room, 37%, about 1 in 3 will meet that criteria. People, once again, with episodic tension type headache, they rarely come to the doctor's office. Other primary headache disorders infrequently appear in primary care office. So cluster and other types of headaches, those often will be in the specialist office. And according to the United Council for Neurological Subspecialties, this changes from year to year. But when I pulled this data, there's only 636 certified headache specialists in the United States. If we're looking at that prevalence of migraine in primary care, once again, population based, I said it ranges depending on which literature you look at from 12% up to 14%. So 12% in the general population. Once again, that primary care waiting room, about 1 in 3 will meet the criteria for migraine regardless of what they're there for. But if they're there and their primary complaint is a headache, 94% of the time the diagnosis is migraine. And lifetime consultation by specialty, here's where I mentioned, nope, they're not in our neurologist's office predominantly. Yes, as we move into more of that chronic migraine on the right hand of this chart, the 15 plus monthly headache days, yes, of course, those patients are also seeing neurologists and headache specialists, but still over their lifetime, the location where they're seeking most of their care is still in our office. What are the current challenges in migraine management? So there's 3 basic challenges we talk about. Access to a healthcare provider. Some of our patients live in rural areas. Even if we want them to see a neurologist, it would be several hours drive and often several months before they can see somebody. Making that accurate diagnosis. Sometimes our patients come in and they tell us, oh, I just have another sinus infection or it's something else. But really diving a little bit deeper, asking those critical questions, looking at their level of disability and impact, maybe using that ID migraine screener, we need to improve and make that accurate diagnosis. And then, of course, the appropriate treatment plan which is very critical for our patients to have success. And when it comes to appropriate treatment plan, this occurs at only 26.3% for those with episodic migraine and less than 5% for those with chronic migraine. So we really want to try to do better for our patients. There are disparities also in the challenges of migraine management. African American and Hispanic patients are both 25% and 50% less likely to receive a migraine diagnosis than white patients, respectively. There's several things that contribute to that, including low socioeconomic background, which is a high risk for underdiagnosis, poor treatment, and therefore worse outcomes. We talked about if we're not treating those migraines and they're getting more of them, they end up in that chronic migraine phase. Household income is associated with migraine prevalence. Low income is associated with being uninsured or underinsured. Therefore, it's harder to get in to see clinicians. It's harder to get in to see those specialists, leading to a chance of inappropriate use of some medications to try to treat those headaches. They can end up with medication overuse. They can progress into chronic migraine and worsen the level of disability. And then, of course, there's a history behind some mistrust with some of these underrepresented groups. Many patients of color, 33% of the African American community and 20% of the American Indian and Native Alaskan community, report experiencing racial discrimination within the healthcare system. So there are 22% and 50% of them avoiding seeking healthcare altogether. And then there's also that level of mistrust within the healthcare community. It's also important to note that less than 30% of patients take their medicines correctly. I'm sure that comes as no surprise to many of you because this happens in many disease states that we treat. So we really want to work on educating and choosing the appropriate medications to really improve this compliance. So a part of it is that poor education. If we're not educating our patients on the benefit of taking these, why we're prescribing them, and potential side effects and how to mitigate those side effects, then there's really going to be poor drug adherence. And then invalidation of the patient's experience leads to dissatisfaction and poor drug adherence as well. So if we kind of dismiss their headaches, dismiss their migraines, dismiss the impact it's having on their quality of life, and just kind of blase prescribe something off the top of our head without having that discussion, they may go home, and if it doesn't work, they may not come back and ask us again because they don't feel like they're feeling validated and legitimized for their symptoms. So once again, to improve that patient satisfaction and drug adherence, we need to know, and caregivers need to know, what patients value. So when we ask patients, what's important to you when we're treating your migraines? They list these three things. They want the medication to work. They want the mode of administration to be what they prefer, and still overwhelmingly, the oral medications are preferred for most patients. And they would love it if there was no or minimal side effects. So these are all things we should keep in mind when we're considering medications we want to prescribe. What is the pathophysiology of migraine? So migraines have a strong genetic component. So 70% of migraine patients have a first-degree relative with a history of migraine. There are also environmental and behavioral factors that can either trigger migraine attacks or make them worse in those patients that are predisposed to this. Hormonal changes, we hear about menstrual migraines a lot. And also, we do see most women who suffer from migraines, when they get through menopause, often their migraines resolve. Stress can trigger it, excessive or insufficient sleep. Some of the medications we prescribe, even medications that we're prescribing for other medical conditions, can actually cause headaches. Smoking can aggravate headaches. Strong odors might be triggers for some patients. Exposure to bright light or flashing lights. Weather changes. A lot of patients will describe when the barometric pressure changes, their migraines are more susceptible. And then lack of exercise. We know that moving our bodies releases endorphins, releases a lot of those uh, anti-inflammatory things that really help balance our bodies. So exercise is important. We always like to talk about chocolate because people will say, oh, if I eat chocolate, I get a migraine. And actually, what the data has actually shown us is that it's not so much a trigger as that the patient is probably in a premonitory or that prodrome period, and they're starting to have cravings. So that hypothalamic activation at the start of a migraine in that prodrome can actually trigger a craving, whether it's chocolate or some other type of food. So it's not so much that it's a cause of the migraine, it's an effect of the changes that are happening in that hypothalamus. Primary neurogenic and secondary vascular events initiate migraine. Back when I was in training, we thought of migraines as being completely vascular, which is why some of the original treatments, both for prevention and acute, focused on blood pressure, focused on the vasculature. So we would use antihypertensives to help prevent migraines. And we would treat with triptans, which cause vasoconstriction during a migraine attack. And then as we start to delve deeper into the understanding of the migraine pathophysiology, we realized there was a strong neurologic component as well. The neurons are involved. A lot of neuropeptides are involved in the release of neuropeptides. And now we kind of came up with this neurovascular hypothesis of what is going on with a migraine. So at baseline, patients with migraine have a state of hyperexcitability in their cerebral cortex due to both genetic predisposition, and then we talked about some of those environmental and behavioral factors as well. This neuronal excitation spreads, which is called cortical spreading depression, resulting in cellular depolarization. That cellular depolarization occurs, which then can lead to aura in those patients who experience aura, which is primarily a cortical phenomenon. We then proceed on to the activation of the trigeminal nerve fibers. And when we activate these nerve fibers, it results in inflammation of the meninges, resulting in that pain. That's the allodynia, that's the headache. And then the stimulation of the nociceptive neurons of the dural blood vessels. And then we also get release of CGRP, which we are now going to talk about. CGRP, the new kid on the block, although I put new kid in quotes because it actually has been looked at in clinical trials and in research for several decades now. CGRP is calcitonin gene-related peptide. It is a 37 amino acid polypeptide in neurons and glial cells, and it is universally present. The receptors to CGRP are located throughout the trigeminal system and multiple brain regions as well as other locations throughout our body. It's in the GI tract, it's on our bones. CGRP is a vasodilator and causes neurogenic inflammation, and it also modulates pain signaling. So once again, it is a potent vasodilator that interacts with the vessel walls, which results in protein extravasation, sterile inflammation, and then the augmentation of pain. So what is the treatment for migraine? What are we going to do? The management of migraines involves acute and preventive treatment. So we always want to be thinking of both of these categories. Every patient that has a migraine should have something that they can take when they get an acute attack. However, remembering that patients with 4 or more headache days a month, which could be 2 attacks, might be 4 attacks, but 4 or more headache days a month, their degree of disability goes way up. We want to have a very low threshold for offering that patient a preventative therapy when appropriate. What are the goals of acute treatment? Number 1, we want to eliminate the headache. We'd ideally like to have pain freedom and freedom from most bothersome symptom. We also would like to prevent the progression of headaches. So our goals for preventive treatment is to reduce the frequency and severity of migraine attacks and make acute attacks more responsive to acute treatment. So what are our goals for acute treatment? So once again, we want rapid relief of headache pain and pain freedom as an ideal. Relief of the most bothersome symptom, including nausea, photophobia, and phonophobia. And then, of course, that sustained pain freedom. Ideally, we'd love not to need to take a rescue medication or a second dose, and just having that first dose really take care of it. It's not always the case with medications, but that is, of course, the ideal. And then we really want to return to full function. We can have a medication, but if I have to go take a nap because I just took my medication and now I'm not functional, maybe I'm going to miss my daughter's soccer game. Maybe I'm going to have to go home from work. So ideally, we'd like an acute medication that they can really return to full function. And then, of course, little to no side effect would be great. So what are our options for acute treatments? So triptans have been the gold standard for 30 plus years. Triptans are a 5-HT1B and 1D receptor agonist. And it's that 5-HT1B that's on our blood vessels, which is why we see that vasoconstriction with triptans. There's also ergots and dihydroergotamine, non-steroidals. There's also non-specific options, some analgesics, some butalbital, and narcotics. And I have narcotics in red here, and I have a big no. And we'll get into a little bit more later, but back before we had some other options, we would resort to these. But we've actually seen in trials and data that butalbital and narcotics actually can make the migraine worse overall. There are non-invasive devices for patients who are candidates for those. They're the new oral CRGP receptor antagonists, and there is one in the class called a ditan, which is lasmiditan, which is a selective 5-HT1F receptor agonist. So unlike the triptans, lasmiditan won't cause the vasoconstriction, but there are some other concerns when you're prescribing this that you need to know about. So what are the most important safety concerns of some of those medications from that previous slide? So triptans and ergots dihydroergotamine are all contraindicated in patients with coronary artery disease, peripheral vascular disease, uncontrolled high blood pressure, and those at risk of cardiac disease. Now, I know many of us for our patients. Often we're still prescribing them because we really didn't have anything else to offer them. But nowadays, I always take that in consideration. We have newer options that for my patients who, are at risk of cardiovascular disease, I really want to consider other things for their acute treatment. Triptans and ergots and dihydroergotamine should not be taken in the same 24-hour period due to the risk of vasoconstriction. There are also risks of medication overuse with triptans. We do see that the more frequently they're using the triptans, then they actually can make those headaches worse. And there's also something called medication overuse headache that can be precipitated. Once again, narcotics and butalbital are nonspecific in treatment of acute migraine, and they can lead to medication overuse, overdose, sedation, abuse, and actually can cause preventives to be less effective for our patients. NSAIDs are contraindicated in many patients due to GI issues or those at risk for GI bleed, and then certain people with kidney conditions. And then with the dietitian lasmiditan, it actually comes with a driving precaution because in clinical trials, they did see sedation with lasmiditan and driving impairment. So there's that 8-hour driving restriction if they're going to take that medication. Medication overuse can lead to progression of episodic migraine into chronic migraine. So going back to that disability bar graph, as you go up that scale, your disability goes up. Opioids, if taken more than 8 days per month, can make this transition occur. Barbiturates, if taken more than 5 days per month, and triptans, if they're taking them at a high frequency, 10 to 14 days a month, can actually push somebody from episodic into chronic. Here's a nice table. I'm not going to read everything to you on this table. I have this printed up at my office, so if I want to have a quick comparator. But the acute medications, once again, those triptans, there's actually 7 available. And then the DHE, dihydroergotamine, there is actually a nasal delivery formulation that's available. The Gpants, which we're going to talk about in detail, there's 2 orals, rimegepant and ubrogepant, and there's 1 nasal Gpant, the zavegepant. There's the ditan I mentioned, lasmiditan, and then there's a few nonsteroidals that are sort of the preferred for migraine acute attack, and I've listed them here. There is some dosing information, and then for prescribing considerations, we put really those contraindications on the right hand of the column. So you don't see anything for the Gpants because there's no real contraindications at Gpants, although there's some considerations for certain patient groups, but no contraindications. I've also included the brand names at the bottom next to the generic names. I know a lot of times, sometimes we forget what the generic is because all of our reps come in and they mark to us with brand names, but so I did include those for your reference as well. So Gpants in the treatment of migraine. CGRP and migraine. First, where's the evidence? Why are we looking at CGRP? Well, what they found is that CGRP levels are elevated during a migraine attack. If they actually drew blood from the jugular vein, they saw high levels of CGRP in patients having migraine attacks. They also found, and I don't know who signed up for this trial, but if they actually infused CGRP into patients susceptible for migraines, they actually produced a migraine attack. And on the flip side, when they infuse CGRP blocking agents, they resolve those migraines attacked in patients with migraine. So the new targeted CGRP blocking molecules are highly effective in the acute treatment of migraine as well as prevention. We have for acute, we have the Gpants, which are small molecules. And then for preventive, we have both the large monoclonal antibodies as well as a few of the small molecule Gpants. So the FDA has approved 4 small molecule CGRP receptor antagonists, aka Gpants, for the treatment of migraine. So these bind into the CGRP receptors, which blocks CGRP, the protein, from binding to those receptors. So ubrogepant is used for acute treatment. Rimegepant is a little unique because it has the FDA approval for acute treatment as well as preventive treatment of episodic migraine. And then you have atogepant, which is FDA approved for the prevention of both episodic and chronic migraine. And then zavegepant, which is a nasal spray for the acute treatment of migraine. So ubrogepant, once again, an oral CGRP receptor antagonist. It's used to treat acute migraines. And then studies show that it's statistically significant percentage of pain freedom and freedom from most bothersome symptom. And it can last up to 12 hours compared to placebo. It is metabolized in the liver. And so oftentimes you might get that alert from the pharmacist if one of their other medications is going through that same pathway. These are acute medications, which are not taken, daily. So unless it's somebody who's on a lot of these chronic medications where you're really worried about that liver impact, most of the time we can get away still with using them, but it's something to take into consideration and something that may need to be dosed down because it does come as 50 and 100 milligrams. It is also better tolerated than triptans and has the least drug-drug interactions. Rimegepant is an oral CGRP receptor antagonist. It's used for both acute and preventive treatment because it does have a longer range of action, can cause pain freedom range from 2 to 48 hours. If you're using it for acute, it's only one tablet in 24 hours, whereas ubrogepant, you can actually redose after 2 hours. And then rimegepant, if you're using it for prevention, it's every other day dosing, and it's an oral dissolvable. Minor side effects such as nausea and vomiting. Atogepant, which is the oral CGRP receptor antagonist that's FDA approved for the prevention of both episodic and chronic migraine. Once daily, atogepant reduces migraine days per month for more than 50% when compared to placebo. The adverse side effects occur at higher doses and include nausea, constipation, and upper respiratory tract infections. Zavegepant is a third generation gepant. So the other ones I mentioned were all considered second generation. This is the third generation gepant approved by the FDA. It's an intranasal spray. It has oral bioavailability. The nice thing about zavegepant is you will get that rapid onset of action. It gets absorbed up in the higher nasal passages and gets absorbed quickly. And so some of those patients can get that relief from pain within the first 15 minutes, lasting up to 2 hours. Altered sense of taste is the most common side effect that my patients complain about. So what do we say when we compare triptans versus the new acute medications? I'm going to drop to the bottom of the slide first and really clarify that there are no head-to-head trials to date comparing triptans with the new acute medications. But a systematic review indirectly compared the performance of triptans versus lasmiditan, rimegepant, and ubrogepant. So they went back and pulled a lot of data from a lot of randomized trials to try to draw some conclusions based on odds ratios calculations in terms of efficacy and tolerability. So the primary outcome was the odds ratio for pain freedom 2 hours after a dose, and secondary outcomes were odds ratios for pain relief at 2 hours after the dose and any adverse events. So in a nutshell, pain freedom and pain relief odds ratio of the new agents were higher than placebo, but lower than the triptans. So they work better than placebo, but if we're doing this odds ratio, the triptans may still be more efficacious. However, the adverse events are higher with both triptans and lasmiditan as compared to the gepants. So summary, the benefits of gepants: better tolerated, fewer milder adverse effects, not associated with progression to chronic migraines due to medication overuse. So they are not seeing, if they're using them too frequently, they're not seeing that medication overuse headaches. And they can be used with other medications as dual therapy. This is where I always talk to my clinicians: offer your patient a toolbox approach. When you have an upper respiratory infection, you don't tell them, oh, only go buy one over-the-counter cold remedy. They might be taking several things. Maybe they want to control the congestion in their nose. Maybe they want to control the cough. We use toolbox approach all the time. We can do that here as well. So they can have more than one option, especially with medications that are not going to be contraindicated to take together. So when do we offer preventive medication for migraines? Once again, that magic 4 or more migraine headache days. And days isn't all bull, because I always come back to not migraine attack, migraine days. A migraine attack can last 3 days. If that's 3 headache days, that's impacting their quality of life. And with impact, if people have sort of these mild migraines, which the definition of a migraine is moderate to severe intensity. So I feel like most patients are getting impacted by their migraine, but not everybody. If your patient says, yeah, I have probably 6 headache days a month due to my migraines, but I go about my daily business, they may not need prevention. But I would argue when you look at those disability scales, we at least want to have that conversation with our patients. So we do offer prevention. We know disability increases 4 more headache days a month. So what are the migraine classifications? Again, to recap, we have our episodic migraine, which is less than 15 days per month. and chronic is 15 or more, which at least 8 of them meeting the criteria for migraine for at least 3 months. And why I think it's so important is I always point out the arrows on this chart are bidirectional. Yes, conversion from episodic to chronic migraine occurs at a rate point of 2.5% per year, but we have a great opportunity with the appropriate treatment to get them going the opposite direction, reduce their frequency of migraine, reduce the burden, reduce the disability. So, what are the FDA approved oral medications for prevention of episodic migraine? And it should say what are the traditional approved, because this doesn't really take into consideration the newer ones we're going to talk about. But you have divalproic sodium, topiramate, timolol, and propranolol. And when I started really getting involved in migraine, I noticed that all of the preventive medications for migraine are not specific to migraine. These are not disease specific medications. We've got anti epileptics, we've got antihypertensives. And then if you look down further at things that are not explicitly approved by the FDA but have shown benefit, you've got tricyclic antidepressants, you have other types of antidepressants. So we were very nonspecific for a very long time, and now we have some better options for patients. Short-term prevention for menstrual migraine, it has been looked at in some of the triptans, but not FDA approved for this indication. Onabotulinum toxin A, I briefly mentioned it early on in the lecture. It was FDA approved for chronic migraine only. It did not show enough of a benefit for episodic migraine. The approved protocol is 155 units injected into 31 individual sites every 12 weeks. Many of our patients will complain that they do feel a wear off around 10 weeks. The sites are listed here. It is FDA approved for chronic migraine in 2010. Its mechanism of action includes inhibition of release of neuropeptides, including CGRP from the peripheral nervous system. GBANs for prevention, I briefly mentioned these. Atogepant, which is that oral CGRP receptor antagonist for the prevention of both episodic and chronic migraine, comes in 3 doses. Remember that side effects do increase with higher doses. And then Rimegepant, which is the one that we talked about, which is a little bit unique because it's approved for acute treatment, but it is also approved for the prevention of episodic migraine. It's an oral dissolvable tablet taken every other day. Anti-CGRP monoclonal antibodies for migraine prevention. These are target-specific medications that block either the CGRP receptor or bind to the CGRP ligand. The net effect is to block the CGRP activity, lessen that migraine cascade of inflammatory activity, and prevent transmission of pain signals to travel to those higher order neurons. Anti-CGRP monoclonal antibodies are large monoclonal antibodies and cannot cross the blood-brain barrier to any significant degree. They also cannot be absorbed through the gut due to their size, which is why these are all either injectable or IV. Anti-CGRP monoclonal antibodies work on the peripheral nervous system. So once again, this is a little bit of a repeat, but something that you might be familiar with from other monoclonal antibodies to treat other disease states. The nice thing about monoclonal antibodies, there's no drug-drug interaction. They degrade by enzymatic proteolysis, so you don't worry about liver or kidney impairment. Overall, very favorable side effect profile in clinical trials. They're approved for the prevention of migraine in adults with episodic and chronic. So once again, we don't necessarily have to worry about, how many exact headache days and whatnot. There's no data in pregnancy and breastfeeding. It's not available once again, an oral tablet. They won't get absorbed. They're expensive. They're grown in cell cultures and they're an injectable. And once again, the CGRP is a vasodilator. So are there cardiovascular considerations? In the clinical trials, there were no red flags. However, it's important to note that for both the monoclonal antibodies and the GPANs in clinical trials, people with active ongoing cardiovascular disease or recent cardiovascular disease were excluded. People with remote issues and were stable were allowed to be in these trials, but anything acute was excluded. With monoclonal antibodies, immunogenicity is possible. And they even saw antibodies against these monoclonal antibodies in the trials, but the impact is unclear. And once again, they're more similar than different. Here's just a quick table, once again, of the 4 that are available on the market. I did include the brand names down below. The arenumab is unique in that it comes in 2 different dosing that you have the option. So you can always start at a lower dose and increase if needed. Fremanezumab is unique in that you can either give it monthly or you can give 3 of the monthly dose all at once, quarterly. So it's good for our patients that travel because these are refrigerated. Galcanezumab is unique in that is the only ligand blocker. The rest of them are I'm sorry, I reversed that. Berenimab is the receptor blocker, and then fremanezumab, galcanezumab, and eptinezumab are ligand blockers. It needs a loading dose of 240 milligrams, and it's given 120 milligrams sub-Q monthly. And then eptinezumab is either 100 milligrams or 300 milligrams. It's an IV infusion. So in my practice, I don't refer out to infusion centers. I leave that for the specialist. But of important to note is it does have a fairly rapid onset of action. So that's nice. The American Headache Society recommends CGRP targeted treatments in the following migraine patients. So, acute treatment in moderate to severe attacks in patients who do not respond or have a contraindication to triptans, and GPANs and monoclonal antibodies for preventive treatment in patients who respond well to acute GPANs. Now, interestingly, the monoclonal antibodies actually were FDA approved prior to the second generation GPANs, prior to those acutes. So, a lot of times we were in a situation where we were testing them in patients who were not responding to their other preventive options. But now, if you have somebody that you've given an acute treatment to and they respond, now feel very confident that they're going to respond to the GPANs or the MABs for preventive. And then, of course, as part of dual therapy in patients with severe attacks, we need a toolbox approach to these patients. Many patients do not respond, especially our chronic migraines. They may need 2 or 3 therapeutics to really reduce their burden. So, what are the complications associated with migraine? With chronic migraines, of course, you can proceed from episodic into chronic migraines. There are migraine triggered seizures have been seen, stroke, which we're going to talk about in just a minute, and then persistent aura without headache. Patients with migraine are more likely to suffer from cerebrovascular and cardiovascular events if they're female, if they smoke, if they have migraine with aura, and then if they use estrogen. So migraine is an independent risk factor for stroke, especially in women under the age of 45. There's a twofold increase in ischemic stroke compared to women without migraine, and this increase is primarily driven by the subgroup of women who have migraine with aura. Approximately 1.5 increased risk of a hemorrhagic stroke in women with migraine, and other risk factors such as smoking can amplify this risk. So, what about our young patients who need estrogen containing contraception and they have a diagnosis of migraine? There is a risk for both ischemic and hemorrhagic stroke, and it's dose dependent. So, the higher the dose, if you have greater than 50 micrograms of ethinyl estradiol, you're going to increase that risk. So, we do want to opt to choose those lower doses of the ethinyl estradiol. So, when we look at those odds ratio, if you're at that 50 microgram or higher, it's between 2.9 and 4.8. Whereas if you're between 30 and 40 micrograms, it's 1.6 to 2.7. And then 1.7 if you're at a 20 microgram, or 0.9 to 1 odds ratio if you're using the progesterone only pills. And that's data pulled from 3 different studies. The ischemic stroke risk is higher in women with aura, odds ratio of 6.1 when they're using combined oral contraceptives versus women without aura, which is 1.8, who use those same contraceptions. So a lot of times if I have a young female patient with migraine with aura, I'll often refer them to my gynecology colleagues and see if maybe doing an intrauterine device is a more appropriate option than putting them on oral contraception. Finally, prognosis. Good news is migraines actually have a favorable prognosis. There are prolonged periods of remission are common. Severity and frequency diminishes with age, especially after menopause in most women. After 15 years, complete remission occurs in 30% of men and 40% of women. So until we get to that point for these patients, that's where we want to come in and really be aggressive with their treatment. So I want to thank you for tuning in to Improving Migraine Management in Primary Care, the role of CGRP antagonism. I'd like you all to take out your cell phone and take a screenshot of this QR code. There's a URL on the left-hand side of the screen. However, QR will pull you right up to your post-survey to receive your certificate. Please complete the brief survey and answer those questions. And then, of course, you have that option of answering the other questions to be able to do those extra credit points down the road. Once again, I'm Dr. Linda Davis, and thank you so much.